Welcome back to the deep dive. Today, we're doing something a little different. Not our typical broad stroke overview.
Right.
We're shifting gears to do something very specific and frankly, quite intense. We are stepping directly into the shoes of a medical officer, someone standing in the ER, maybe the ICU, during a high-stakes outbreak.
It's good to be here. And you're right, this is not a casual chat.
Well,
We are dissecting the clinical protocols from that government order, the GO number 2363. So if you are a clinician, a public health official,
an infectious disease specialist.
this is your blueprint. We aren't just skimming the surface today. We need to understand the rigorous architecture of how to manage a biosafety level 4 pathogen in a real hospital setting.
So let's frame this right. Imagine you are the duty medical officer. You need to know the enemy, how it moves, how to spot it, and exactly down to the milligram, how to treat it.
And we are focusing on the Kerala context, as per the source material.
Let's start with the agent itself. We all know Nipah is scary, but strictly speaking, what are we fighting?
We're fighting a highly virulent RNA virus. It's from the paramyxoviridae family, genus Nipah virus. Now, globally, we look at two major outbreak profiles, and it's really crucial to distinguish them.
Why is that?
Because the transmission dynamics are they're completely different. You have the Malaysia outbreak from 98-99.
That was the pig-associated one, right?
Correct. That was primarily driven by contact with respiratory secretions
Right.
and urine of infected pigs. But the profile we're dealing with in India and Bangladesh is distinct.
Okay.
Here, the transmission chain starts with a bat-to-human spillover,
Hmm.
followed by a very dangerous human-to-human spread.
And looking at the distribution map in the slides, India is basically painted red. I mean, we fall squarely within the Terapus bat distribution zone.
We do.
This isn't some freak occurrence. It's a persistent geographical risk.
Exactly. The natural reservoir is that large fruit bat, the Parapus genus. And when you look at the genetics, it gets really interesting.
How so?
We have two main genotypes, the B genotype from Bangladesh and the M genotype from Malaysia. Now look at the Kerala genotype. It shares an 85.14% similarity with Malaysia's,
Okay.
but a 96.15% similarity with the Bangladesh genotype.
So genetically, what we're dealing with is much, much closer to the Bangladesh strain.
Yeah.
Does that explain the higher mortality we see or the transmission patterns locally?
It definitely aligns with the transmission efficiency we see. And speaking of history, the Kerala data is just stark.
Yeah.
You had the initial event in Kozhikode, May 2018, 18 confirmed cases, 4 probable.
Only 2 survivors.
Only 2. Then a single containment success in Kochi in 2019, and another single case in 2021.
It seems like we're getting better at catching it early, at least. But let's look at the when. The guidelines mention seasonality.
Typically, yes. The data points to a window from, say, December to May. This usually correlates with bat breeding and their feeding pattern. However, and this is a massive caveat for any clinician listening, we've seen breakthrough infections outside this window.
Like the case in September 2023.
Exactly. So while seasonality guides our surveillance, it cannot become a blinder. If a patient presents with symptoms in September, you don't rule out Nipah just because the calendar says off-season.
That's a critical point. Okay, so let's talk about that spillover. How does this virus actually jump from a bat to a patient?
The primary route is via fruit contaminated by bad secretions,
Mhm.
Urine, saliva, reproductive fluids. The guidelines explicitly flag the consumption of raw date palm sap, or tari.
A classic vehicle.
It is. But we also have to watch for secondary hosts. In Malaysia, it was pigs. In the Philippines in 2014, it was horses.
But for the doctor on the ground, the nightmare scenario is human-to-human transmission. What's the biggest red flag in the patient history?
Clustering. That is your vital clinical clue. If you see symptomatic cases clustering among close contacts or family members, especially adults, your index of suspicion needs to hit the ceiling.
Right.
This isn't like dengue, where you might see neighbors getting sick from mosquitoes. This is intimate, contact-based spread.
Let's get right into the triage protocols. A patient walks into casualty. The guidelines have very strict case definitions. Walk me through a suspect case.
All right, so to label someone a suspect case, they must be from an affected area or locality. Then they need to present with acute fever A&E, at least one of the following.
Okay, one of what?
Either a new onset of altered mental status, or a seizure, or a severe headache, or cough and shortness of breath.
That respiratory component is so important. We often just think of the encephalitis part.
Absolutely. It can present as pure respiratory distress. Now, if that suspect case dies before we can get samples, but they had a clear epidemiological link.
Like they lived in the same village or something.
Right, or had hospital contact, they become a probable case.
And a confirmed case is strictly lab-based.
Yes. That requires Nipah virus RNA identification. So PCR from a throat swab, urine, serum, or CSF, or, actual isolation of the virus itself.
The guidelines also have a very detailed section on defining a contact. This is critical for the contact tracing teams. Who actually makes the list for that 21-day surveillance?
The net is cast very specifically. A close contact is someone who was admitted to the same ward or shared a room. It includes anyone who had direct close contact during the illness.
Including the ambulance staff.
Yes, during transport. It also includes anyone at funeral or burial rituals, and critically, anyone who touched blood, body fluids, or linens.
Linens is a word that really stands out there. It's a reminder of the environmental stability of the virus in fluids.
It is. And all of these contacts are monitored for the longest incubation period, which is 21 days.
So we have our suspect. Let's talk about the clinical picture. What is the progression?
It usually starts very non-specifically. Fever, severe fatigue, muscle pain, headache, vomiting.
But then it crashes.
It crashes hard. You see the progression to altered mental status, convulsions, and respiratory distress. You're really looking at three main syndromic presentations: encephalitis, myocarditis, or ARDS.
And the mortality rate mentioned in the slides it's just terrifying.
It completely changes the psychology of the treatment room. We're looking at a case fatality rate of 40% to 75%. In some outbreaks, it is hit 100%.
100%.
This is why the management guidelines are so incredibly aggressive.
Let's discuss the diagnostics. If I suspect Nipah, I assume I'm not just calling the phlebotomist for a routine draw?
No, you absolutely are not. If you treat this like a standard blood draw, you are endangering your entire facility. Nipah is a biosafety level 4 pathogen.
So what's the rule?
Sample collection should only be done after the patient is admitted to an isolation facility. Full stop.
What's the PPE requirement for the person taking the sample?
It's intense. N95 mask, double surgical gloves, gowns, goggles, and foot covers. And the hand hygiene protocol is rigorous. Wash with soap and water for 30 seconds, then alcohol sanitizer, both before you don and after you doff.
And what samples do we need to grab?
You need the full panel. A throat swab in viral transport medium, 10 milliliters of urine in a sterile container, 5 milliliters of blood in a red vacutainer, and if you can, 1 to 2 milliliters of CSF in a sterile container.
Once we have the samples, getting them to the lab is a whole logistical operation in itself. The triple container method mentioned in the slides, can you break that down?
This is absolutely non-negotiable for safety. Layer 1. The vials go into a Ziploc bag with enough absorbent cotton to soak up the entire volume if it leaks.
Okay.
Layer 2, that bag goes into a second sealed Ziploc bag. And layer 3, that secondary carrier goes into a hard container, which is then sealed with impermeable tape.
And that hard container goes into the cold chain box?
Correct. A thermocol box with ice packs to keep it at 2 to 8 degrees Celsius. And here's a crucial administrative detail. The case sheets and documentation are pasted outside the container.
Ah, so the lab techs don't have to dig inside?
You do not want them digging inside a potentially contaminated box just to find the patient's name.
The workflow for testing is also hierarchical, right? We don't just send this anywhere.
No, absolutely not. It flows from Trivandrum to Ernakulam, then to the National Institute of Virology, NIV, in Alappuzha, and finally to NIV Pune for the final word.
All right, let's move to the part every medical officer is waiting for, part 4. Treatment protocols. The patient is isolated, the sample is sent. What are we doing right now?
General supportive care is the foundation.
Oh.
So isolation, PPE, fluid balance.
Yeah.
But there's a very specific instruction regarding fluid management that might feel counterintuitive.
Go on.
The guidelines recommend a fluid restriction.
Restriction usually in sepsis or a viral fever, we're pumping fluids.
Exactly. But here we are terrified of cerebral edema. The protocol calls for a 30% fluid restriction in adults. In children, you give 2/3 of the maintenance requirement. Unless they're in shock, you have to walk a very, very tight line between hydration and swelling the brain.
Now let's talk drugs. The pharmacotherapy section lists specific agents. Let's start with ribavirin. It's an old drug, but the dosing here is incredibly aggressive.
It's a massive load. Ribavirin is a nucleoside analog. For Nipah, on day 1, you give a loading dose of 2 grams stat.
2 grams? That's 10 of the 200 milligram capsules at once.
10 capsules stat. That tells you we aren't just treating a viral load. We are trying to outpace a replication rate that destroys tissues in days.
Wow. And after day 1?
For days 1 through 4, you continue with 1 gram, so 5 capsules every 6 hours. Then days 5 through 10, you taper down to a 3-2-3-2 capsule regimen.
That's a lot of pills. What are we watching out for in terms of toxicity?
Hemolytic anemia is the big one. Yeah. Bone marrow suppression. And it's a teratogenic, which is a major ethical and clinical consideration in pregnant patients.
The slides also mention monoclonal antibodies, specifically M102.4. This feels like the precision weapon in the arsenal.
It is. The mechanism is really fascinating. M102.4 recognizes the G envelope protein of the virus. It basically sits on the virus's receptor binding site.
And prevents it from attaching to the host cell.
Exactly. It stops it from attaching to the FNB2 protein.
So it locks the door.
It locks the door so the virus can't get in. But remember, this is an investigational drug. You can't just order it from the pharmacy. It requires ICMR support, ethics committee approval, and very strict compassionate use protocols.
We also have remdesivir, which everyone knows from COVID. Why is it in the Nipah protocol?
Well, remdesivir, or GS5734, has broad-spectrum activity against paramyxoviruses. In vitro studies showed it effectively reduced replication in human lung endothelial cells.
Dosage is similar.
It's the standard. 200 milligram IV loading dose, then 100 milligrams daily for up to 12 days.
And favipiravir.
That's our backup, really, used on compassionate grounds. It's an RDRP inhibitor. The loading dose is high 1,800 milligrams twice a day on day 1, then 800 milligrams twice a day for 2 weeks.
What are the main concerns there?
You have to watch the liver and kidney function like a hawk with this one.
There's a note on post-exposure prophylaxis here, too. If I prick my finger where a nurse has a high-risk exposure, what do we grab?
Remdesivir is actually the preferred agent for PEEP. It's been found effective against both the Bangladesh and Malaysia genotypes. Favipiravir is an alternative, but the data is mostly on the Malaysia genotype.
Let's move into the ICU. Part 5. Management of complications. The guidelines introduce a term that caught my eye. NAIDS.
Yes, this is a critical concept. It stands for Acute Onset Immune Dysrhythmia Syndrome. Think of NAIDS as Nipah's version of a sepsis-like collapse.
So it's not just the virus, it's the immune system overreacting.
It's the immune system misfiring so badly that it causes systemic dysregulation. This is where we start to consider immunomodulators.
Like steroids.
Yes, steroid pulse therapy. But there are very specific triggers. You'd only consider it if the Glasgow Coma Scale, the GCS, drops to 8 or below, if there's rapid neurological deterioration, or if you see evidence of a grade 3 or 4 cytokine storm.
Managing the encephalitis and raised intracranial pressure, the ICP, that seems to be the main battle for survival.
It is. You keep the head elevated at 15 to 30 degrees for venous drainage. For osmotherapy, we're using 3% saline at 5 milliliters per kilo, or mannitol at 0.5 to 1.0 grams per kilogram.
Simple things, too.
Crucial things. You have to maintain euthermia and euglycemia. A fever or a sugar spike in this brain state is absolutely disastrous.
And if they seize?
Lorazepam 4 milligram IV is first line, or phenytoin or levetiracetam. If the ICP just keeps rising despite all this, you have to proceed to rapid sequence intubation.
Then there's the heart, myocarditis.
Right. If the heart is inflamed, you're going to need inotropes. But look at the selection logic in the guidelines. We used dobutamine.
2 to 20 mics per kilogram per minute.
If the systolic BP is above 90.
And if they are hypotensive, SBP below 70.
Then you switch to norepinephrine. You need that vasoconstriction.
What about the lungs? If the patient goes into ARDS, how are we ventilating them?
The ventilator strategy is essentially lung protective ventilation on steroids. You are aiming for very low tidal volumes, specifically 6 millimeters per kilogram of predicted body weight.
High PEEP.
High PEEP. Your respiratory rate is set higher, 20 to 30 per minute. The goal is in SpO2 of 88 to 95%. You're trying to oxygenate them without blowing out the lungs, which are incredibly friable in this state.
Let's say we win the battle. The patient stabilizes. Part 6 covers discharge and follow-up. When can we actually let them go?
Okay, if it was just a suspect case, they go home once they're symptom-free and test negative. But they still have to do home isolation for the full 21 days.
But for a confirmed case, the bar is much, much higher.
Much higher. They have to be clinically stable. But the lab requirement is strict. Negative RT-PCR results from the throat, from urine, A&D from blood.
And not just once.
Not just once. You need 2 negative panels at least 5 days apart.
And even then, it's not over.
No. They go into isolation at home for another 4 weeks. And we schedule follow-ups at day 28, day 56, and day 90.
Why such long-term follow-up?
Because the guidelines explicitly warn about relapse and late-onset encephalitis. The virus can hide in immunologically privileged sites like the CNS and just flare up months later.
That is a sobering thought. The document wraps up with a prevention and algorithm summary.
The core message is simple. Stop the spillover. Avoid raw date palm sap. Avoid bat-bitten fruits. The treatment algorithm flowcharts just reinforce the logic we discussed.
If suspect and symptomatic, Intense supportive care and test.
Right. If positive, remdesivir or ribavirin. If negative, you repeat the test after 48 hours.
We've reached the final slide. Local battle, global recognition.
It's a moment of reflection, really.
Yeah.
The Institute of Human Virology in Baltimore honored Kerala's public health response. It just emphasizes that while these protocols are incredibly strict and clinically demanding, this local battle has established a global standard of care.
It really highlights that while the virus is a terrifying biological agent, the human response, structured, scientific, and disciplined, is our best defense.
Absolutely. And I want to leave the listener with one final provocative thought from that epidemiology section. We cling to this idea of seasonality December to May. But those breakthrough infections, like the one in September, they really challenge our comfort zone. It forces us to ask, is the viral behavior evolving?
Yeah.
Or does our surveillance just need to be permanently year-round?
A critical question for every medical officer to keep in mind as they suit up. That concludes our deep dive into the Nipah management guidelines. Stay safe, stay rigorous. Welcome back to the deep dive. Today, we're doing something a little different. Not our typical broad stroke overview.
Right.
We're shifting gears to do something very specific and frankly, quite intense. We are stepping directly into the shoes of a medical officer, someone standing in the ER, maybe the ICU, during a high-stakes outbreak.
It's good to be here. And you're right, this is not a casual chat.
Wow.
We are dissecting the clinical protocols from that government order, the GO number 2363. So if you are a clinician, a public health official,
An infectious disease specialist.
this is your blueprint. We aren't just skimming the surface today. We need to understand